Welcome to Systemic Mycosis. This is quite a lengthy video and you can pause and review anytime that you'd like. Our learning objectives as listed here are aimed towards helping you understand and remember the common fungi that cause endemic and opportunistic systemic infections. And these are the references. We begin with the endemic systemic mycosis, which are a group of diseases caused by fungi from soil. These fungi are dimorphic and transmission is mainly through inhalation of their conidia. Most cases are symptomatic or mild. Upon inhalation of the conidia, the alveolar macrophage engulf and digest the conidia, and they are capable of inactivating the conidia. This usually leads to granulomatous inflammation with activation of your humoral immunity and cell-mediated immunity. These processes in turn activate macrophages to enhance fungicidal capacity of the host immune system, leading to resolution. Residual granulomata may retain dormant organisms, and these have the potential for reactivation when one becomes immunocompromised. These individuals then would become symptomatic with the additional possibility of spreading infection to different organs. Some of these fungi display alpha-glucan in their cell walls, which may mask pathogen-associated molecular patterns that trigger host immune response. We will be tackling the four primary causes of endemic systemic mycosis. We begin with coccidiomycosis, which is mainly caused by Coccidioides immitis. When you culture it, you will see the colonies to be white to tan-colored and cottony in consistency. From that colony, if you get specimen for microscopy, you will see arthoconidia that fragment easily to release spores. The arthrospores are lightweight and very infectious. Specimens can be pus, sputum, or tissue. You will see a spherule with double refractile wall. You can get infection through inhalation, and you only need less than 10 arthoconidia to get infected. Most of the time, the infection is self-limited. Systemic spread is rare, but it can be fatal. More commonly, you get asymptomatic respiratory infection where you develop antibodies, which results in positive skin test after 2 to 3 weeks. Mild flu-like symptoms may appear 1 to 2 weeks after infection. They may also present with skin lesions like erythema nodosum or erythema multiforme, which are like hypersensitivity reactions. More than half of cases have changes seen in chest X-ray. Approximately 1% can become disseminated and fatal. They have noted racial predilection in Filipinos, African Americans, Native Americans, Hispanics, Asians. And they also note that it is more commonly seen in the pregnant. C. immitis has estrogen-binding proteins and elevated levels of estradiol and progesterone stimulate its growth. Specimens include sputum, exudate from skin lesions, spinal fluid, blood, urine, and tissue, like the lung biopsy. Fresh specimens should be used for detecting spherules under the microscope. KOH or calcofluor white stain will facilitate in finding the spherules and endospores. Fungal culture can be done using IMA or BHI blood agar slants at 37 degrees centigrade. Confirmation can also be done using animal inoculation or specific DNA probe. There's a skin test making use of coccidioidin or spirulina to check for presence of antibodies. There are serologic studies specifically to test for the presence of precipitating antibodies, your IgG and IgM, which can be present 2 to 4 weeks after infection. Complement fixation antibody tests can be positive up to 6 to 8 months after infection in low titers. But if you find high titers, especially in disseminated coccidioidomycosis, it usually signifies poor prognosis. Primary infection with CMITIS is self-limited and usually requires only supportive treatment. Disseminated infection will require treatment with amphotericin B through IV for several months. Azoles are only moderately effective in treating chronic pulmonary infection, but they are easier to administer and have less side effects. For histoplasmosis, this is caused mainly by Histoplasma capsulatum. In nature, capsulatum grows as a mold associated with soil and avian habitats, enriched by nitrogen in guano and bird feces. At temperature less than 37 degrees centigrade, they grow into brown mold colonies, but appearance may vary. In tissue or in vitro enriched medium at 37 degrees centigrade, the hyphae and conidia convert to small, oval yeast cells, and in the tissue, the yeasts are seen within macrophages. Histoplasmin is filtrate antigen used for skin testing, with more than 95% of asymptomatic individuals showing a positive delayed type skin reaction. Serologic testing for both yeast antigen and mycelial antigen can be done. Most individuals will be asymptomatic. After inhalation and action by the alveolar macrophages, the yeasts may disseminate to the reticuloendothelial system. Inhalation of conidia, which develop into yeast, are engulfed by alveolar macrophages, within which they are able to replicate. In more than 95%, the resulting cell-mediated immune response leads to secretion of cytokines that activate macrophages to inhibit the intracellular growth of the yeasts. Individuals may present with acute pulmonary histoplasmosis, chronic pulmonary histoplasmosis, or severe disseminated histoplasmosis. Specimens for culture include skin scrapings, sputum, bronchial washings. Microscopy will show small ovoid cells within macrophages in tissue sections, best viewed with special stains. Histoplasmin skin test becomes positive soon after infection and remains positive for years. Repeated skin testing stimulates production of antibodies, and this can interfere with diagnostic interpretation. Specimens are cultured in rich media such as your glucose, cysteine blood agar at 37 degrees centigrade, or on SDA or IMA at 25 to 30 degrees centigrade or room temperature. This is incubated for a minimum of 4 weeks. Growth is confirmed using in vitro conversion to yeast form, detection of species-specific antigen or PCR. Complement fixation tests for antibodies to histoplasmin or yeast cells become positive within 2 to 5 weeks after infection. They also rise during progressive disease and then decline to very low levels when the disease is inactive. For the immunodiffusion test, antibodies against the H antigen signifies active infection, while those for the M antigen may be due to repeated skin testing or past exposure. Radioassay or enzyme immunoassay is one of the most sensitive tests for circulating antigens. These drop after successful treatment and recur during relapse. While cross-reactions may occur, this antigen test is more sensitive than conventional antibody test in AIDS patients with histoplasmosis. Acute pulmonary histoplasmosis usually is treated by rest and supportive therapy. Itraconazole is given for mild to moderate infection. In disseminated disease, amphotericin B is usually curative, although patients may need prolonged treatment and monitoring for relapses. For blastomycosis, this is caused by blastomyces dermatitidis. On SDA at room temperature, it grows as a mold which is described as white or brownish colony with branching hyphae, bearing spherical ovoid or piriform conidia on slender terminal or lateral conidiophores. At 37 degrees centigrade or in the host, it converts to a large, thick-walled, multinucleated spherical yeast that usually produce single buds. The bud and the parent yeast are attached to each other with a broad base. The bud enlarges to the same size as the parent yeast before it detaches. The yeast colonies are wrinkled, waxy, and soft. Blastomycin is the antigen used for the skin test. Patients are often negative or lose their reactivity, and false positive cross reactions occur in people exposed to other fungi. The frequency of primary pulmonary stage is unknown because there is no adequate skin or serologic test with which to assess subclinical or resolved primary infections. So most of them are asymptomatic, and if they do present with symptoms, it is usually nonspecific. When dissemination occurs, skin lesions on exposed surfaces are most common, seen as raised ulcerated verrucous granulomas with advancing border and central scarring, which can evolve to ulcers. Blastomycosis can involve the bone, genitourinary tract, and CNS. Using skin scrapings, sputum, and bronchial washings, you may visualize under direct microscopy the thick-walled yeast cells with buds attached on a broad base. Identification is confirmed by 1. Conversion to yeast form after cultivation on rich medium. 2. Extraction and detection of B. dermatitidis-specific antigen A, or 3. Specific DNA probe. Overall, serologic tests are not as useful for the diagnosis of blastomycosis compared to other endemic mycosis. In patients with localized lesions, a 6-month course of itraconazole is effective. Severe cases of blastomycosis are treated with amphotericin B. Paracoccidioidomycosis is caused by Paracoccidioides brasiliensis. Cultures of the mold form grow very slowly and produce chlamydospores and conidia. The features are not distinctive. At 37 degrees centigrade on rich medium, it forms large multiple budding yeast cells. The yeasts are larger and have thinner walls than those of Blastomyces dermatitidis. The buds are attached by narrow connection. Paracoccidioidomycosis starts with inapparent lung infection, which may be dormant for decades. When dissemination occurs, the yeast spreads from lungs to other organs, particularly the skin and mucocutaneous tissue, lymph nodes, spleen, liver. On histology, you will see central caseation with the yeasts frequently observed inside giant cells. Confirmation again has to be conversion to yeast formed by in vitro growth at 37 degrees centigrade. Serologic testing is most useful for diagnosis with antibody to paracoccidioidin measured by complement fixation or immunodiffusion. Healthy persons in endemic areas do not have antibodies to P. brasiliensis. Paracoccidioidin, if used for skin tests, may cross-react with coccidioidin and histoplasmin. Itraconazole appears to be most effective against paracoccidioidomycosis, but ketoconazole and trimethoprim sulfamethoxazole are also efficacious. Severe disease can be treated with amphotericin B. Key points: The endemic mycosis are characterized by distinct geographic distribution and are caused by dimorphic environmental molds. More than 90% begin by inhalation of conidia, and within the lungs they are converted to distinctive yeast cells. In their endemic areas, rates of infection with coccidioides, Histoplasma capsulatum, and Paracoccidioides brasiliensis are very high, but approximately 90% of infections occur in immunocompetent individuals who are asymptomatic or present with self-limited disease. Immunocompromised individuals are at significantly greater risk of developing disseminated disease. Incidence of disseminated disease is significantly higher in males. Serologic tests for serum antibodies have diagnostic and prognostic value. We now go to opportunistic systemic mycosis. Development of opportunistic infections are determined by the underlying predisposing condition of the host. Candida and related yeasts are endogenous opportunists since they belong to the normal mammalian microbiota. Other opportunistic mycoses are caused by exogenous fungi, which are globally present in soil, water, and air. For this lecture, we will focus on the more common pathogens, mainly Candida, Cryptococcus, Aspergillus, Mucormycosis, Pneumocystis, and Thalaromycosis. We begin with candidiasis. Several species of the yeast genus Candida are capable of causing candidiasis. They belong to the normal flora of the skin, mucous membranes, and gastrointestinal tract. They colonize the mucosal surfaces of all humans soon after birth. Candidiasis is the most prevalent systemic mycosis, with the most common agents being C. albicans, Paracillosis, glabrata, and tropicalis, among others. Widespread use of fluconazole has given rise to azole-resistant species. In culture or tissue, Candida species grow as oval budding yeast cells, and they also form pseudohyphae when the buds continue to grow but fail to detach, producing chains of elongated cells that are pinched or constricted at the septations between cells. Only C. albicans is dimorphic among all species of Candida. In addition to yeast and pseudohyphae, it also can produce true hyphae. On agar media, they produce soft, cream-colored colonies with a yeasty odor. In other words, it smells like beer. Two simple morphologic tests distinguish C. albicans from other species. One, after incubation in serum for about 90 minutes at 37 degrees centigrade, the yeast cells of C. albicans will begin to form true hyphae or germ tubes. And two, on nutritionally deficient media, it produces large spherical chlamydospores. Sugar fermentation and assimilation tests can be done to confirm the identification of other species of Candida. Increase in number of local Candida and damage to the skin that permits local invasion by yeast and pseudohyphae give rise to cutaneous or mucosal candidiasis. Use of broad-spectrum antibacterials often promotes large increases in endogenous population of Candida in the GIT, oral, and vaginal mucosa. Systemic candidiasis occurs when Candida enters the bloodstream and the innate phagocytic host defenses are inadequate to contain the growth and dissemination of the yeast. The critical host defense against systemic candidiasis is an adequate number of functional neutrophils capable of ingesting and killing the yeast cells. Candida cells elaborate polysaccharides, proteins, and glycoproteins that not only stimulate host defenses but facilitate the attachment and invasion of host cells. Risk factors associated with superficial candidiasis include AIDS, pregnancy, diabetes, young or old age, birth control pills, and trauma. Trauma that includes burns, maceration of the skin. Candida can present as primary or secondary mycotic infection. In the oropharynx, thrush can occur on the tongue, lips, gums, or palate. It presents as patchy to confluent whitish pseudomembranous lesions composed of epithelial cells, yeast, and pseudohyphae, which can lead to formation of an intractable biofilm. Yeast invasion of the vaginal mucosa leads to vulvovaginitis, characterized by irritation, pruritus, and vaginal discharge. Interdigenous infection occurs in moist, warm parts of the body, such as the axilla, groin, and intergluteal or inframammary folds. It can be seen in obese and diabetic individuals. Newborns having no established balanced microbiome are susceptible to extensive diaper rash and skin infection by Candida. Interdigital lesions between fingers may be seen following repeated prolonged immersion in water. Invasion of the nails and around the nail plate can give rise to onychomycosis. These are the other forms of candidiasis based on anatomic location. Specimens include skin and nail scrapings, fluid, and tissue. Direct microscopy will reveal budding yeast cells and pseudohyphae. Yeast colonies are examined for the presence of pseudohyphae. They are further examined for the presence of germ tubes or chlamydospores. Interpretation of positive cultures varies with the specimen. Any positive culture from a normally sterile body site is significant. For example, sputum cultures have no value because Candida is part of the oral microbiota. Yeast isolates can be speciated phenotypically by using any of several commercial kits to test for the metabolic assimilation of a battery of organic substrates. Chrome agar is a useful commercial medium for the rapid identification of several Candida species based on the fungal enzymatic action on chromogenic substrates in the medium. Thrush and other mucocutaneous forms of candidiasis are usually treated with topical nystatin or oral ketoconazole or fluconazole. Eliminating contributing factors like excessive moisture or antibacterial drugs will help in accelerating resolution of skin lesions. Systemic candidiasis is treated with amphotericin B, with or without oral flucytosine, fluconazole, or capsofungin. The most important preventive measure is to avoid disturbing the normal balance of microbiota and intact host defenses. Candidiasis is not communicable since virtually all persons normally harbor the organism. Cryptococcosis is caused by Cryptococcus. Unlike other pathogenic fungi, these yeast cells possess large polysaccharide capsules. Cryptococcus neoformans occurs worldwide in nature and is isolated readily from dry pigeon feces as well as on trees, soil, and other sites. Cryptococcus neoformans is inhaled, and from the lungs, these neurotropic yeasts typically migrate to the CNS where they cause meningoencephalitis, and it also has the capacity to infect other organs. In culture, Cryptococcus species produce whitish mucoid colonies within 2 to 3 days. On microscopic evaluation, the spherical budding yeast cells are surrounded by a thick non-staining capsule. All species are encapsulated and possess urease. The capsular polysaccharides, regardless of serotype, have similar structure. They are long, unbranched polymers consisting of a 1,3-linked polymannose backbone with beta-linked monomeric branches of xylose and glucuronic acid. During infection, the capsular polysaccharide or glucuronoxylmanan is solubilized in spinal fluid, serum, or urine. This can be detected by an enzyme immunoassay or by agglutination of latex particles coated with antibody to the polysaccharide. Infection starts with inhalation of yeast cells from environment. They are usually dry, minimally encapsulated, and easily aerosolized. Primary pulmonary infection may be asymptomatic or present with flu-like symptoms, which often resolve spontaneously. In the immunocompromised, the yeasts may multiply and disseminate to other body parts, but with CNS preference. There may be skin lesions, but chronic meningitis, which can resemble brain tumor, brain abscess, degenerative CNS disease, or TB meningitis, is the major clinical manifestation. Course of cryptococcal meningitis may fluctuate over long periods, but untreated cases are ultimately fatal. Specimens include CSF, tissue, exudates. For direct microscopy, specimens are examined in wet mounts, both direct and after fixing with India ink to delineate the capsule. Tissue sections need special stains and are examined for globose to avoid budding yeast cells surrounded by wide gelatinous capsules. Colonies develop within a few days on most media at room temperature or 37 degrees centigrade. Combination therapy with amphotericin B and flucytosine has been considered the standard of treatment for cryptococcal meningitis, although addition of flucytosine remains controversial. Inadequately treated AIDS patients will almost always relapse when amphotericin B is withdrawn, and they require suppressive therapy with fluconazole. Bird droppings, particularly bichon droppings, enrich growth of C. neoformans and serve as reservoir. The organism grows luxuriantly in pigeon excreta, but the birds are not infected. Next is aspergillosis. Aspergillus species are ubiquitous saprobes in nature, with Aspergillus fumigatus as the most common human pathogen. Aspergillus species grow rapidly, producing aerial hyphae that bear characteristic conidial structures, which are long conidiophores with terminal vesicles on which phyalides produce bicipital chains of conidia. Species are identified according to morphologic differences in size, shape, texture, and color of the conidia. In the lungs, alveolar macrophages are usually able to engulf and destroy the conidia, but if the affected is immunocompromised, then efficiency is diminished. Conidia could swell and germinate to produce hyphae that have a tendency to invade pre-existing cavities, producing your aspergilloma or fungus ball, or blood vessels. In some atopic individuals, development of IgE antibodies to the surface antigens of Aspergillus conidia elicits an immediate asthmatic reaction upon subsequent exposure. In others, the conidia germinate and hyphae colonize the bronchial tree without invading the lung parenchyma. Normal hosts exposed to massive doses of conidia can develop extrinsic allergic alveolitis. Specimens are sputum, bronchial washings, and tissue biopsies. Blood samples are rarely positive. Colonies are usually fast-growing, white, yellow, yellow-brown, brown to black or shades of green, and they mostly consist of dense felt of erect conidiophores. KOH of molds reveal conidiophores that terminate in a vesicle covered with either a single palisade-like layer of phyalides or a layer of subtending cells which bear small whorls of phyalides. Species are identified according to the morphology of their conidial structures. In histologic sections, hyphae of Aspergillus are seen to be hyaline, septate, and uniform in width, and branch dichotomously. The immunodiffusion test for precipitins to Aspergillus fumigatus is positive in more than 80% of patients with aspergilloma or allergic forms of aspergillosis. But antibody tests are not helpful in the diagnosis of invasive aspergillosis. Instead, serologic tests for circulating cell wall galactomannan is diagnostic, although not entirely specific for aspergillosis. Aspergilloma is treated with itraconazole or amphotericin B and surgery. Invasive aspergillosis requires rapid administration of either the native or lipid formulation of amphotericin B or voriconazole, often supplemented by cytokine immunotherapy. Allergic forms of aspergillosis are treated with corticosteroids or disodium chromoglycate. Bone marrow transplant units use air conditioning systems with heavy filters, and monitoring of airborne contaminants should be done. Some patients at risk for invasive aspergillosis are given prophylactic low-dose amphotericin B or itraconazole. We now go to mucormycosis. In the broadest sense, mucormycosis is any infection caused by a member of the zygomycetes family. Zygomycetes are primitive, fast-growing, terrestrial, largely saprophytic fungi with a cosmopolitan distribution. The medically important orders belong to Mucorales. Mucormycosis is often associated with acidotic diabetes, severe burns, and immunosuppression. The major clinical form of rhinocerebral mucormycosis, which results from germination of the sporangiospores in the nasal passages and invasion of the hyphae into the blood vessels, causing thrombosis, infarction, and necrosis. Thoracic mucormycosis follows inhalation of the sporangiospores with invasion of the lung parenchyma and vasculature. Specimens can come from skin scrapings, sputum, and needle biopsies from pulmonary lesions. In tissue sections, you'll find broad, infrequently septate, thin-walled hyphae, which often show focal bulbous dilations and irregular branching. They grow rapidly on laboratory media, producing white to gray or brownish abundant cottony or downy colonies. Identification is based on the sporangial structures. Treatment consists of aggressive surgical debridement, rapid administration of amphotericin B, and control of the underlying disease. Many patients survive, but there may be residual effects such as partial facial paralysis or loss of an eye. Next, we have pneumocystis. Pneumocystic Girovechi is the causative organism for pneumocystis pneumonia. It used to be a major cause of death in AIDS patients. Growth in the lung is limited to the surfactant layer above the alveolar epithelium. In non-AIDS patients, infiltration of the alveolar spaces with plasma cells leads to interstitial plasma cell pneumonitis. Plasma cells are absent in AIDS-related pneumocystis pneumonia. Blockage of the oxygen exchange interface results in cyanosis. Pneumocystis jirovecii is an extracellular pathogen. It has morphologically distinct forms. 1. The thin-walled trophozoites, and 2. Cysts, which are thick-walled, spherical to elliptical, and contain 4 to 8 nuclei. The cysts can be stained with silver stain, toluidine blue, and chalcofluor white. It contains a surface glycoprotein that can be detected in sera from acutely ill or normal individuals. Specimens are bronchoalveolar lavage, biopsy, or induced sputum. A specific monoclonal antibody is available for direct fluorescent examination of specimens. It cannot be cultured. Acute cases are treated with trimethoprim, sulfamethoxazole, or pentamidine, isethionate. No natural reservoir has been demonstrated, and the agent may be an obligate member of the normal flora. Mode of infection is unclear, and transmission by aerosols may be possible. Last among the opportunistic systemic mycosis is penicilliosis. Mycosis marnifae is the dimorphic mold that causes penicilliosis, which was originally thought to be a species of penicillium. At ambient temperatures, the mold form grows rapidly to develop a green-yellow colony with a diffusible reddish pigment. The septate branching hyphae produce aerial conidiophores bearing phyalides and basipetal chains of conidia. In tissue, the hyphal forms convert to unicellular yeast-like cells that divide by fission. The major risk for infection is immunodeficiency due to HIV/AIDS, TB, corticosteroid treatment, or lymphoproliferative disease. Clinical manifestations include fungemia, skin lesions, and systemic involvement of multiple organs. Treatment is with a defined course of amphotericin B followed by itraconazole. Key concepts to remember about opportunistic mycosis are: the causes are either normal flora or environmental yeasts or molds. Innate host defenses, which are your neutrophils and monocytes, are crucial for protection against systemic candidiasis, invasive aspergillosis, and mucormycosis. Most patients with HIV/AIDS develop mucosal candidiasis. CD4 counts less than 100 cells per microliter are at risk of developing cryptococcosis, pneumocystis pneumonia, aspergillosis, penicilliosis, or talaromycosis. Diagnosis of invasive aspergillosis or systemic candidiasis is difficult. Successful management of opportunistic mycosis involves early diagnosis, rapid administration of appropriate antifungal therapy, and control of underlying condition or disease. Antifungal chemotherapy. Here's a summary of the antifungals that are administered systemically, and we'll go through them briefly one by one. Amphotericin B is a major polyene antibiotic, which is a metabolite of streptomyces. It is most effective against severe systemic mycosis. It has a broad spectrum and it kills the fungus by forming complexes with the ergosterol in fungal cell membranes, resulting in membrane damage. It has stronger affinity for ergosterol than cholesterol, and this is important because the cholesterol is the predominant sterol in mammalian cell membranes. Flucytosine is the fluorinated derivative of cytosine. It is used primarily together with amphotericin B for treatment of cryptococcosis or candidiasis. It has good tissue penetration, including blood-brain barrier. Flucytosine is transported into fungal cells by permease, converted by cytosine deaminase to 5-FU, and incorporated into 5-fluorodeoxyuridylic acid monophosphate, which in turn interferes with the activity of thymidylate synthetase and DNA synthesis. The azoles have both imidazoles and triazoles, which are used to treat a wide range of systemic and localized fungal infections. They interfere with ergosterol synthesis by blocking the cytochrome P450 dependent 14-alpha demethylation of lanosterol, which is the precursor of ergosterol in fungi. Azoles are fungistatic drugs. Echinocandins are a relatively new class of antifungal agents that perturb the synthesis of pervasive cell wall polysaccharide beta-glucan. The first licensed drug, caspofungin has shown efficacy against invasive aspergillosis and systemic candidiasis. Griseofulvin is an orally administered antibiotic derived from penicillium. It is used to treat dermatophytosis. It's poorly absorbed and is concentrated in the stratum corneum, where it inhibits hyphal growth. It does so by interacting with microtubules within the fungus and disrupts the mitotic spindle function, resulting in inhibition of growth. Terbinafine is an allylamine drug which blocks ergosterol synthesis by inhibiting squalene epoxidase. It is orally administered to treat dermatophyte infections. Going now to topical antifungals, we start with nystatin, which is a polyene antibiotic, which is structurally related to amphotericin B with a similar mode of action. It is used to treat local candidal infections of the mouth and vagina. A variety of antifungal azoles are too toxic for systemic use and are available for topical administration. Clotrimazole, miconazole, and other azoles have a broad spectrum of activities. Other topical antifungals like tolnaftate and naftifine are used in the treatment of many dermatophyte infections and tinea versicolor. Key concepts for antifungal chemotherapy are: 1. Effective therapy relies on rapid identification of the fungus, administration of the appropriate drug, and management of any underlying disease or condition. The fungicidal polyene amphotericin B has a broad spectrum with rare resistance. However, renal toxicity and other side effects must be monitored and managed. Azoles are static with limited range of antifungal activity. Echinocandins are static and are proven effective against Candida. This is the end of the lecture on systemic mycosis and antifungal chemotherapy. Thank you.